Okay, so you guys have sent in some really heavy stuff this time around. A lot of it focusing on postpartum hemorrhage.
PPH.
Yeah, PPH. So for this deep dive, we are going to be trying to really pull out the important info from what you sent and give you a clear picture of what's going on with this potentially life-threatening complication. We're talking after both vaginal and cesarean births here.
Right.
And I think it would be good to come away from this understanding exactly what it is, why it happens, how it's recognized, and what absolutely needs to be done.
Absolutely. And it's a really important area, and unfortunately one that we're seeing an increase in the United States.
Oh, really?
Yeah. There was research done in 2022 by Escobar and colleagues.
Yeah.
That alone tells you that this is something we need to understand very well.
Yeah, for sure. And then if you look even more globally, the World Health Organization in 2022 said that PPH is actually the leading cause of maternal death.
Worldwide.
Worldwide. Yeah, it accounts for something like 70,000 deaths each year. And even here in the U.S., data from Smith in 2022 shows about 11.4% of maternal deaths are because of PPH every year. So those numbers really emphasize how serious this is.
They do. And it's also important to understand that it's not just like one event and then it's over.
Mm-hmm.
So Belfort in 2024 talks about how there's primary PPH, which happens within 24 hours of the birth, and then there's secondary PPH, which can happen anywhere from 24 hours to even 12 weeks
Wow.
after the birth. So it's something to even think about after those initial hours are over.
So it's not just an immediate thing.
Right.
Yeah. So ACOG, the American College of Obstetricians and Gynecologists has a very clear definition. Escobar and his team pointed this out also in 2022. They define PKH as cumulative blood loss greater than 1,000 milliliters. So that's like over a liter, right?
Yeah.
With signs and symptoms of hypovolemia within 24 hours of birth, regardless of how the baby was delivered. So it's not just the quantity of blood loss, but also, is it affecting the birthing person? Are they showing signs of hypovolemia, which means essentially not enough fluid volume in the blood?
Right. And Belford in 2024 talks about how if it's not taken care of, it's not managed correctly, there can be some serious consequences.
Yeah.
Including things like organ failure, shock, thrombosis, so it increases the risk of blood clots, acute respiratory distress, and even anemia.
Wow.
And then in more extreme cases, even a hysterectomy or abdominal compartment syndromes can occur.
Which is really scary. And Smith noted in 2022 that any delay in recognition and diagnosis can lead to a poorer outcome. So time is of the essence here.
Yes, definitely.
Okay, so we know what it is. We know how serious it is. Let's get into the why. What's going on in the body that's causing this excessive bleeding?
So the research you sent explains that excessive bleeding can happen between when the placenta separates from the wall of the uterus and when it's fully expelled or removed from the body.
Right.
But the most common cause of primary PPH, I think it accounts for something like 80% of cases, is something called uterine atony. Belfort talked about this in 2024.
Okay, uterine atony. So the uterus, which has been working so hard this whole time, right, suddenly isn't doing its job.
Exactly. So it has a really important job after the baby's born. It has to control the bleeding.
Right.
And it does that by contracting and retracting. And it basically clamps down on the blood vessels at the placental site.
Yeah.
So it's almost like it makes like a fist and just clamps down on those vessels.
I see.
And when you have uterine atony, it just can't contract strongly enough. So those vessels are left open and it can bleed significantly.
That makes a lot of sense. So what would make it less likely to contract properly? What are some of the things that Belfort mentioned in 2024 that are risk factors for uterine atony?
Well, one of the biggest ones is if you've had PPH in a previous pregnancy.
Right.
That's a big one. Also, if you've had chorioamnionitis, which is infection of the amniotic fluid and membranes during pregnancy or labor,
I see.
that can increase your risk. And then if you have fibroids, which are just those non-cancerous growths in the uterus, those can also increase your risk.
Okay. So those are some more biological things. What about in the actual labor and delivery itself? Does anything increase the risk there?
Yes, so if labor is induced or augmented with medications, or if they use magnesium sulfate therapeutically, that can increase the risk.
I see.
And then anything that causes the uterus to be overdistended, so if you have like a really big baby, macrosomia,
Right.
or if you're carrying multiples,
Right.
polyhydramnios, so too much amniotic fluid,
Okay.
anything that causes the uterus to really be stretched, that can make it less likely to contract afterwards. Uterine inversion, although it's rarer, that can also be a risk factor. And then finally, if you needed a blood transfusion for PPH in a previous pregnancy, that increases your risk in future pregnancies.
Wow, it's a pretty comprehensive list
It is.
of potential things that could contribute. So beyond uterine atony, the sources mention other kind of categories of causes for PTH. Can we break those down a little bit?
Yeah. So Belfort, again in 2024, broke it down into trauma, tissue, and thrombin. So when we talk about trauma, we're talking about like lacerations or tears, to the cervix or perineum.
Okay.
During the delivery, episiotomy, bleeding related to a cesarean section, hematomas in the genital or rectal area.
So actual injury during the birthing process can cause bleeding.
Right.
Makes sense.
Then there's tissue. So retained placental fragments, placenta previa or accreta,
Right.
uterine inversion we talked about.
Right.
But also, even if you pull too hard on the umbilical cord, trying to deliver the placenta, that can cause the cord to detach or it can cause uterine inversion, and that can lead to massive hemorrhage.
That's a good warning.
Yeah. And then thrombin, so problems with blood clotting. So a history of coagulopathies like von Willebrand disease or thrombocytopenic purpura or DIC.
Yeah.
All of those can affect the body's ability to stop bleeding after the birth.
Okay. So it's kind of like a perfect storm of potential reasons why this might happen.
Right.
So now I think we should talk about, okay, what can be done? What is the therapeutic management of all this?
So the initial management, if we're talking about uterine atony, because that's the most common cause, is going to be things like fundal massage, uterotonic medications. Belfort talked about that in 2023. Bimanual uterine compression, where the provider places one hand inside the vagina and one hand on the abdomen to compress the uterus.
Oh, wow.
And then for patients who are hemodynamically unstable, so meaning their vital signs are showing signs of shock, fluid resuscitation, and blood transfusions.
Okay, so these are interventions that need a skilled medical team.
Right.
To do all that. So this brings us to, there's a big emphasis in all the stuff you guys sent in on the nursing assessment.
Yes.
So how important is that?
It's very important. So those first few hours, really the whole postpartum period, is really critical for preventing, assessing for and managing PPH. And Smith, in 2022, contrasted it to things like infections. He really stressed that hemorrhaging can become life-threatening really quickly. So nurses and everyone on that team really needs to be on it.
Okay, so what are the key steps that are outlined? What are they looking for in those first few hours?
So it starts with a thorough review of the patient's history, looking for all those risk factors that we talked about. Their labor and birth history, vital signs, super important. Watching those trends really carefully. Smith also talked about that in 2022. And here's something to really keep in mind. Because a birthing person's blood volume increases so much during pregnancy, sometimes by as much as 50%, they might initially lose quite a bit of blood before you see any changes in their blood pressure.
Yeah.
However, you might see them getting dizzy or palpitations, tachycardia.
Right.
So an increased heart rate. And this is what's called compensated shock. It's almost like they have a bigger reserve tank. So you lose some fluid before it really drops dramatically.
So you can't rely on just the blood pressure.
Right.
What about the actual physical assessments that are going on?
The physical assessment, the most important thing is checking the uterine tone. So feeling the fundus, which is the top of the uterus, and seeing how firm it is and where it is in the abdomen.
Okay.
So you want to feel a firm uterus. There should be some bright red bleeding. And if it feels soft or boggy, that's a sign of uterine atony. So meaning the uterus is not contracting effectively.
Okay.
Also, you're going to assess the amount of bleeding, which can be hard because it can pool inside the uterus, that soaks into the pads and things.
Right.
So it can be hard to get a really accurate measurement.
Yeah, it's not exact.
It's not. There's a take note in the material about the position of the uterus that nurses are paying attention to.
Yeah, tell me about that.
That's really important. So if it's soft and boggy and it's deviated from the midline, so it's off to one side or the other, that suggests that the bladder's full.
Interesting.
And the bladder, when it's full, it's taking up space and it's actually preventing the uterus from contracting properly.
Oh, so that's a simple intervention potentially.
Very simple.
Make sure the bladder is empty.
Make sure the bladder's empty.
Through that.
So they're also going to assess the perineal area and any surgical incisions for hematomas. So these are kind of like a localized bluish swelling under the skin.
Yeah.
They can cause pain and difficulty urinating, especially after operative deliveries.
Right.
They're going to be checking the skin and mucous membranes for signs of coagulopathy. So things like bleeding gums, petechiae, which are those tiny little red or purple dots on the skin, ecchymosis, checking the Feeyi sites for bleeding, making sure that the amount of lochia, so the vaginal discharge after birth, doesn't seem too heavy.
Okay.
And then finally remembering that because of that increased blood volume, they might not show those signs of shock
Right away.
until later.
So it's a very thorough, ongoing assessment of the physical and also the vital signs. So that leads us to, okay, what do you do about it? What is the immediate nursing management, the interventions that happen when you identify this excessive bleeding?
So the big takeaway from the material is that PPH can happen unexpectedly and can become life-threatening very quickly.
Yeah.
So the nurse is really the first line of defense in observing that and initiating a prompt response and continuing to assess while getting that whole medical team involved.
Right.
Because every patient is at risk. Active management of the third stage of labor, so from when the baby's born until the placenta is delivered, and a really rapid response to any bleeding is super important.
So when that bleeding is identified, what are the first things that happen? I know we want to get that uterus contracting. What are they doing?
So immediate fundal massage, uterotonic medications, and IV fluids to resuscitate.
Okay, and there's a concept mastery alert that's highlighted in the material that I think is really important to mention.
Yeah, so that's a really good point about safety. So before you even start massaging the fundus, the nurse has to place one hand above the symphysis pubis, so that bony prominence you can feel in the front of the pelvis, below the uterus.
Okay.
And the reason for that is so you can support and anchor that lower part of the uterus,
Okay.
because you don't want to cause uterine inversion,
Right.
which is where the uterus turns inside out.
That sounds terrible.
It is. And it can happen if you don't support that lower segment.
So anchor, anchor, anchor.
Anchor before you massage.
Yeah.
And then if that doesn't work, if the medications don't work, if the massage doesn't work, then we're talking about more aggressive interventions.
Okay.
Bimanual compression, internal uterine packing, balloon tamponade. So those are going to be done by the healthcare provider, usually. And then at the same time, you're going to investigate if there are any other causes.
Right.
Get those lab tests done, CBC, type in cross-match, coagulation studies.
Okay, so if the bleeding is not stopping, I noticed in the material that the threshold for considering a blood transfusion seems to be pretty low.
Yes. So they say don't hesitate to give a blood transfusion if there's ongoing significant blood loss, or if the estimated loss is over 2,000 milliliters. That's from Smith in 2022. And then a hysterectomy is a last resort if the bleeding just won't stop and it's life-threatening.
Okay. So let's break down some of the nursing skills. So fundal massage, there's a whole nursing procedure that's outlined in the material.
Yeah.
What are the key steps that they're doing there?
So it talks about how first you explain to the patient what you're going to do. One gloved hand goes above the symphysis pubis,
Right.
to support that lower uterine segment. The other gloved hand massages the fundus in a circular motion. It actually says, don't massage too vigorously or for too long.
Oh, really?
Yeah, because it can tire the muscle out and it can make the atony worse.
Okay.
So you're constantly checking for firmness, and that if it is firm and contracted, you can apply gentle downward pressure to help expel the clots. But you never express clots before the fundus is firm. Again, you can cause that inversion.
Right. Got it.
Then you help the patient with perineal care, get a fresh pad on there. And then there are uterotonic drugs. There are a lot of medications listed.
Yeah.
So basically, the idea behind all these uterotonic drugs is to contract the uterus, right? Keep it contracted. And that helps clamp down those blood vessels at the placental site.
Makes sense.
So they mentioned oxytocin, misoprostol, dinoprostone, methylorganovine maleate, carboprost-tromethamine.
Wow, that's a lot of medications.
It is a lot. Misoprostol is actually considered off-label use in the U.S.,
Okay.
but it is used. But which drug to use, the route, the dosage, that's all going to be the healthcare provider's clinical judgment. And they say that giving a uterotonic drug right after the placenta is delivered, that's first-line therapy. And it can really help to prevent it in the first place.
So just get it contracting early.
Get it contracting early. And then ongoing monitoring. So
Right.
maintaining that IV and preparing for a second one if you need a blood transfusion. Getting the blood drawn for a type and cross-match
Okay.
and other labs. While those oxytocics are going in, you're checking that uterine tone, you're looking at the bleeding, checking those vitals super frequently, probably every 15 to 30 minutes, looking at that CBC, assessing their level of consciousness, making sure they're not having any changes that would suggest they're not getting enough blood flow to their brain.
Okay. So we talked about how important it is to keep the bladder empty.
Yes.
How is that typically managed?
So they'll often just place an indwelling catheter just to make sure that the bladder's empty and stays empty. Because if it's full, it can displace the uterus, and it can cause those contractions to be less effective.
Okay. And what about if they suspect that there are retained placental fragments?
So the nurse is going to prepare the patient for removal, which is usually done manually by the provider. The provider needs to stay with the patient afterwards to really assess their bleeding and make sure that there's not something else going on. And the nurse also assists with suturing any lacerations.
So lots to do. And it sounds like they need to be ready for anything.
Right.
What happens if it's just not stopping?
So if it's not stopping, the nurse has to anticipate transferring the patient to the OR.
Right.
They're going to notify the blood bank. They're going to watch for a hypovolemic shock. And there's a really great table in the material that shows the manifestations of shock based on the percentage of blood volume loss.
Can you break that down for us a little?
Yeah, so in mild shock, which is like a 15 to 25% blood volume loss, they might have things like diaphoresis, weakness, increased heart rate, slight decrease in blood pressure. Moderate shock, which is like 25 to 35%, paleness, restlessness, or agitation. Oliguria, which is decreased urine output, and a bigger drop in blood pressure. And then in severe shock, which is 35 to 50% or more, that's where you see a huge drop in blood pressure, confusion, loss of consciousness. They might be hemodynamically unstable. Anuria, meaning no urine output.
Wow. So that's a lot to keep track of.
It is.
And when someone's going into shock, the interventions are happening on multiple fronts, right?
Right. They want to control the bleeding.
Right.
The most important thing. Then they're going to restore the oxygen carrying capacity, so they might give a blood transfusion.
Right.
And then they want to maintain tissue perfusion, so make sure the organs are getting enough oxygenated blood. So it's a total team effort.
It takes a village.
It does.
Now, the sources also talk about patients who have bleeding tendencies. So what are the key things that providers need to think about with these patients?
So accurate diagnosis is very important. Teaching them self-care measures,
Okay.
like how to do fundal massage at home, how to track their bleeding, make sure they're not taking anything that could affect clotting like aspirin or NSAIDs, preventing trauma, doing procedures, giving them support.
Okay.
If they have a specific coagulopathy or if they develop DIC, then they're going to need specific medications for that. DIC, they might need to go to the ICU.
And then there's a really helpful take note in the material about the 5 causes of PPH and what you do about each one.
Yes.
Do you want to quickly go through that?
Yeah. So uterine massage, oxytocics, retain placental tissue, evacuation, oxytocics, lacerations or hematoma, surgical repair, thrombin, so your bleeding disorders, blood products, and uterine inversion, replacement, and oxytocics.
Okay, so that was a really good summary of how to approach those different situations.
Right.
Finally, let's talk about what can be done to prevent this in the first place.
So they mention avoiding routine episiotomies. So only doing them when absolutely necessary. Having that experienced labor and birth nurse present.
Okay.
Really having that continuous monitoring. Staff education, PTH drills, making sure everybody knows what to do if it happens.
Right.
Identifying anemia, screening for coagulopathies early. When the placenta is delivered, making sure that it's complete, there's no fragments. Assessing for lacerations immediately after birth, reassessing vital signs, looking at the bleeding, being aware of the patient's preferences about blood transfusions. And then finally, this is from Kogut and colleagues in 2022, having that PPH cart ready to go.
Yes, so important.
So that if it happens, you have everything right there.
Well, this has been a really comprehensive overview of postpartum hemorrhage.
It has.
And it is a very serious and unfortunately increasingly common complication. It's the leading cause of maternal death worldwide.
Right.
And often it comes down to the uterus not contracting effectively. So early recognition through a really, attentive assessment, looking at that uterine tone, the amount of bleeding is so important.
It is.
And a bunch of different interventions, from massage to medications to even more advanced procedures, are absolutely crucial. And now that you've listened to this, you know so much more about this important part of postpartum care and why vigilance, preparedness, and quick action are so vital.
Yes. And it makes you wonder, even with everything we know and all these protocols we have in place, it's still increasing.
It is.
So what more can we be doing to prevent PPH-related morbidity and mortality, both here in the U.S. and globally?
Right.
And I think that's a really important question to think about.
Yeah.
Because it's not just clinical, it's social, it's economic. There's so many factors involved.
Well, thank you for listening to this deep dive
Thank you.
into postpartum hemorrhage, and we will see you next time.